Anyway, so my job is to talk about acute management of these fractures and also to kind of just clear out some of this thing of what is it that we are trying to answer when we look at classification. It's a relatively common injury. The problem with that is the injury is physeal, intra-articular, intracartilaginous. And it's because part of the fracture line extends in the cartilage, it's quite difficult to kind of evaluate it. Notorious for late displacement, so you can't just rely on your initial assessment or even first few days assessment, and complications are plenty. So first challenge in the management of this is you need to get your diagnosis. You can't miss these. Sometimes they're not as glaringly obvious as supracondylar fracture. It can be just subtle localized swelling. So clinical suspicion and adequate imaging. And when I mean adequate imaging, you have an AP and a lateral. That's not enough for an evaluation of a lateral condyle fracture. It's a mandatory that you need to take a third view, an internal oblique view, in any case of suspected lateral condyle fracture. So that's the first take-home message. You need a third view for this when you're evaluating them. Secondly, when you look at these three images, what is it that you're trying to look at? When you've diagnosed it, you want to see the displacement as a surrogate measure for instability. And by displacement, it is on any of the three views at the metaphyseal side. So the cutoff is 2 millimeters or more than 2 millimeters, but it's the metaphysis where you can see the slightly displaced fractures actually hinging open. So the maximum displacement is likely to happen at the metaphyseal site. So that is where you need to usually measure, but it can be in any of the three views. So then the next step is you want to say, okay, you got it displaced or unstable, but you want to know actually is it stable or unstable, and that's where that's what guides you to how you want to manage it. And stability, as Ishwar alluded to, is dependent on the intactness of the articular hinge. And that's difficult to kind of visualize on plain X-rays because it's cartilaginous, you can't see it. So you have to use surrogate measures. You have to see whether, if it's too much displaced, it's likely to be, the hinge would have been disrupted. You see what the fracture line pattern is. Are they both converging? Are they kind of parallel fracture lines? You can use ultrasound and MRI, but that's not used in routine practice, so I wouldn't recommend that. Where in doubt, the best way that most of us assess the intactness of the articular hinge is by doing an arthrogram, which means you have to take the patient under anesthesia and most often end up fixing it as well. So this is just to illustrate what you can see. This is all that you can see on the plain X-ray. You can see the fracture line. You don't know where exactly it's ending. Yesterday you saw a technique of arthrogram. So you inject some dye, you can see the outline, and you can see that the articular cartilage is intact. Okay, it's always injected not from the lateral side, it's usually from the posterior side because you don't want to obscure the lateral mass. So that allows you to kind of understand what is happening to the articular hinge. Now, after your clinical and radiological evaluation, what is it that you're trying to look at? You want to get them into whatever classification you want to choose, whatever works for you. But you want to see whether it's stable, which you would obviously treat it conservatively, unstable, which is the grossly displaced and rotated, so that is the which would get operated treatment, and you have a group which comes into the indeterminate or potentially unstable. Okay, and that's a gray area where you have to watch them closely, or if you have a low threshold to intervene, fix them. But that is all your classifications, whichever way you want to choose. Most of us use now the song classification, but that's what you need to kind of be familiar with. Don't get confused with the multiple classifications. Have one classification which works for you and try and get them, all your lateral condyle fractures, into any of these three categories. So this picture is fairly kind of common. It's used in all talks. But what you really want to see is 4 and 5, more than 2 millimeter displaced. So they are clearly unstable. So there's no doubt about it. So use the 2 millimeter cutoff. The in-between one, the 3, where the displacement is less than 2 millimeters, but the fracture line is running parallel. That is also considered unstable. Okay? And 1 and 2 are relatively stable injuries. Okay? So even though there's a lot of information there, you need to start looking at the displacement and see how the fracture line runs. So if you have identified it as a stable injury and you're going to kind of treat it non-operatively, it is not just plaster and forget about it. And why is that? It's indicated for incomplete or undisplaced fractures. It's an above elbow cast with the elbow in 90, forearm neutral, wrist in slight extension. There is a risk of displacement which is maximal during the first 10 days. So you need to have X-rays you can't just put it in plaster and forget about it. And if need be, you can't visualize the fracture well, take the plaster out and get those x-rays. And the plaster to continue until there is union. So here is a case which was interpreted by the treating surgeon as an undisplaced fracture or a minimally displaced fracture. You can see that there's a large gap. I would disagree with that. But he chose to treat it in plaster, and he did a follow-up x-ray. And you really can't make out what's going on here, what's displacement. So this is unacceptable. And that's what it ends up as. It's simply because your initial assessment was not foolproof enough. At 3 weeks, you find that this is what's happened. Okay? So your initial assessment was wrong. Your follow-up assessment, you did not. What is the point of taking an x-ray if you really can't see the fracture line? Take the plaster off, because it's not going to displace during the removal of this thing, plaster. You need to kind of actually visualize the fracture lines well. So this is a truly incomplete fracture. It's stopping well short of in the metaphysis. So you can treat it conservatively, but you really need to know what is going to happen. Do they displace in the interim? Depending on what you read, there is some risk of displacement even in the minimally displaced. Not necessarily the incomplete fracture, but which are less than 2 millimeter displacement, they can displace. So you need to watch them closely. So here is another example. This was conservatively managed. No, sorry, that was a previous case slide. So here is a fracture line. You can see this, I would call potentially unstable. And in my interpretation, this is a potentially unstable, and therefore I would offer surgery. Surgery was offered for this. Father refused. Wanted to continue with conservative management. Perfectly fine. You need to watch it. That's the only thing. At 1 week, x-rays out of plaster so that I can clearly see that the fracture has not displaced. Okay? And some of these where I'm even more concerned, because they can displace up to about 10 days. So there's another x-ray at 2 weeks. This one I could see the fracture line, it's not displaced, so you can continue with conservative management. So that is follow-up pattern. You need to watch them at least up to about 10 days, whether you want to do it as weekly intervals for the first 2 weeks to be on the safe side, that's up to you. If it displaces during your follow-up, is it a bad outcome? No. You need to pick them up early and have it treated. So the outcomes are comparable even if you have a displacement within the first 2 to 3 weeks. So nothing is missed. The problem happens only if you miss the displacement and it presents as a non-union. Now, when do you go in for close reduction and fixation? When you know that the articular congruity is intact or can be achieved. And so here is a displaced fracture. Whatever classification you want to use, this is not a rotated fracture, but it's clearly displaced. So, however you reduce it, and your choice of fixation can be, depending on the metaphyseal fragment, can be either wires or screw. You use your surrogate measure of displacement to determine whether close reduction will work. So here again, close reduction, you can see that the fracture gap is closed. Do an arthrogram. That's the only way that you can make sure that the articular cartilage is intact. If you haven't restored the continuity of the articular cartilage, then you have to open it. So fixed with K-wires, went on to heal without any untoward issues. Here is another case, slightly older child, larger metaphyseal fragment, not rotated, displaced fracture, clearly well past the 2 millimeter displacement mark. Reduction is done, provisional fixation. So I just want to show you a different form of fixation. You can use a screw as well. Confirm that through an arthrogram that the articular cartilage is intact. Fixation with a screw. Where you have a large metaphyseal fragment, you can use that and you can put a screw, a single screw to hold it. Again, post fixation, you can see that the articular cartilage is intact. Full functional recovery, and screw is removed at that stage. So in displacement which are more than 2 millimeter, where you want to fix it, where you're sure that the articular cartilage is intact. So some people use the 2 to 4 millimeter cutoff, but you need to confirm that displacement is just an indicator. You need to make sure that the articular cartilage is intact with an arthrogram if you're doing close reduction and pinning. So wire versus screw, intuitively you would think that screws do better in terms of union. There is no such evidence. The only evidence is that with wires, there is slightly increased risk of infection and elbow stiffness. But otherwise, there is no big difference. If you have a large metaphyseal fragment in an older child, fix it with a screw, I would urge you. If you're using wires, and if you're doing an open reduction, make sure that the wires are passed not through the wound. Sometimes you try to kind of push the indications of a closed reduction. So this is rotated, not completely flipped over. It's worthwhile trying a closed reduction, and you can find that you can actually kind of improve things. Okay? Check it again. So even though this is a rotated fragment which I managed closed reduction, in my current practice, I would say that you need to be careful about stretching the indication. So rotated fragment where you're really not sure about the articular cartilage, I would say don't push the indications to the closed reduction, go in for an open reduction where it's significantly rotated, because you can't really appreciate an axial plane rotation with an arthrogram. So last couple of slides on open reduction, just the principles, where it's significantly displaced, rotated fragment where you're not able to kind of achieve a closed reduction or fracture dislocations. And the important thing is where you're not sure, where you're not comfortable interpreting an arthrogram or visualizing an articular cartilage, do not hesitate, go in for an open reduction. Okay, so that's a fracture dislocation. It's impossible to kind of get it reduced with closed manipulation. Few things about surgical approach. The tissue planes are actually opened up for you with the fracture itself. The fracture hematoma opens up the tissue planes. Be aware of the blood supply. Don't dissect in the front and the back. The blood supply to the capitulum comes from the posterior side. You need to use indirect reduction maneuvers. It's not the metaphyseal reduction which is critical. So you really need to be able to see the articular congruity. You're working down a dark, deep hole. Sometimes people use headlights for this. Don't pass wires through the wound because they carry a higher risk of infection. Wires pass separately. Okay, so that's the management algorithm. So as the higher stages of displacement, closed reduction and pinning can be used. Stage 5, which is rotated, I would urge you to kind of consider open reduction and fixation. So using another classification, the same algorithm. The principle remains the same, significantly displaced, articular cartilage disrupted, go in for an open reduction. So in conclusion, mandatory 3 views. Whatever classification you use, sorry. So whatever classification you use, you need to get information about this. Yeah, that's what we're trying to use at. So that's another important thing. In plaster, if you're treating it, monitor closely. And I think the next talk is on late presentations.
Thanks, Manoj.